Welcome in, everyone. We're going to give it a moment and let folks join our room. We are recording, just FYI, but welcome in to the clinical issues meeting. Nice to see all your faces for those of you who are got your video on. And Destiny, if you can just let me know when you think we have everyone in the room, that would be great.
Looks like we have about 21 participants, so we can go ahead and
Fabulous. Okay. Well, good morning or good afternoon, everyone. So this is the NNPTC clinical issues meeting, and we're kind of reviving our group. This is our first Zoom meeting. We met via the phone for many years, and then we sort of took a break, and CNPTC has taken on coordinating and facilitating along with the NNPTC3, the coordinating center. So thank you so much, Destiny. She's doing the tech behind all of this. And this is our first meeting, and we're so lucky to have Dr. Geisler with us today from UAB, as well as one of our sister PTCs, the Southeast STD HIV Prevention Training Center. And this is an informal meeting, so Dr. Geisler is going to give a presentation on M. genitalium, and then I believe there's going to be a few cases toward the end, but we actually didn't discuss this. Are you okay with people stopping you? This is
oh, sure. Yeah, I mean, however you want to do it. What I'll try to do is maybe like pause between each slide just to see if anybody says question, because I can't see the chat, or you can, or if there's something in the chat, you can tell me and
yeah,
let me know.
I'll keep an eye out for the chat. And then I know that we'll have time for questions at the end. There are a few questions that were emailed to me too on this topic. So
okay.
It should be fairly informal, and I'm really happy that we're all here, and I'm going to hand it over. I'll do a brief introduction just. So Dr. Geisler, as many of you are aware, is a professor of medicine and epidemiology in the Division of Infectious Diseases at the University of Alabama at Birmingham, and he is an internationally recognized expert on chlamydia and MGent, and we really are using his expertise here today to get us up on MGent, specifically focusing on antimicrobial resistance and clinical implications of that. And I'm going to leave it at that. There could be a lot longer introduction, but
yeah, probably better to save the time. No, sure.
Yeah.
But thank you so much for the introduction, and thanks for inviting me to give this presentation. And like I said, I'm completely fine with it being informal. I've got I'm going to go through some of the key points about resistance and treatment for MGent, and then I've got a few cases at the end, which I think will really pull together some of the challenges that we face already in trying to manage this infection. I'll just briefly mention my only disclosures that are relevant to M. genitalium are that I'm currently involved in a research study that's supported by Hologic, and I've previously received speaker honoraria from Hologic, and Hologic makes one of the several different assays that are approved for M. genitalium testing. Before I get into resistance and management, I really want to give you some basic background in case, not all of you are familiar with this organism, about just its significance, how we diagnose it, and then we'll get into resistance and treatment. And so Mycoplasma genitalium is a sexually transmitted mycoplasma, and based on more recent data, this is a pretty common sexually transmitted infection, and it's certainly more common than gonorrhea. And even though earlier population-based studies suggested that chlamydia was a little bit more common than Mycoplasma genitalium, I think if you look at least clinic-based studies, their prevalence is more similar, and some of the recent studies published suggest that it may be becoming even more prevalent than chlamydia itself. And it's often not by itself. When you find it, you may find it as a co-infection with other STIs. In particular, chlamydia and trichomonas seem to be the two other concomitant STIs that you see more commonly. Like chlamydia, the majority of infections are asymptomatic or clinically mild, but also like chlamydia, it is an established cause of clinical syndromes. In men, that's urethritis, and in women, it's cervicitis. And if you take men with persisting urethritis or women with persisting cervicitis, M. genitalium is going to be one of the most common causes in that setting, and that's because they're often failing the initial treatment that you give for those clinical syndromes. Now, unlike chlamydia, where there's a lot more data about reproductive and perinatal complications, there's less data from Mycoplasma genitalium. And because the fact there's less data, that's one of the reasons why CDC is not, kind of gone out and started recommending asymptomatic screening yet, is because we don't know if you have relatively, asymptomatic or mild disease, does that lead to reproductive or perinatal complications? And, there is some data reporting an association with these complications, but it's just not consistent, and the data is just not strong enough. So we don't really know with certainty. There is very good data, however, like many STIs, that genitalium does increase the risk for HIV acquisition. So there's been a meta-analysis that published on that, and the studies are pretty strong in that area. And like chlamydia, the reported predictors for genitalium are quite similar: younger age, certain socio-demographic differences, and then also certain sexual behaviors, particularly new or multiple sexual partners. So I guess think of this a lot like chlamydia, really, other than we just don't have enough data so far on reproductive and perinatal complications, and that's in terms of clinical presentation. Detection's a whole nother animal. So in chlamydia, we can grow it pretty easily, just like we can grow, gonococcal organisms pretty easily. You cannot grow genitalium easily. So it's very difficult. It's a very fastidious organism. It's a really laborious effort to try to grow it. It takes weeks just to get it growing, and you have to monitor its growth by PCR. It would take you 3 to 6 months most of the time to be able to get it to grow outside of a cell line when you can start actually growing it on a plate. And so if it's so difficult to grow, it's certainly not useful for clinical care. And there just aren't many labs that are actually doing it. Our lab at UAB, to my knowledge, is only one of 3 labs in the world right now that's actually growing this organism. As you know, growing an organism can be quite important if you want to do things like traditional susceptibility testing. You would need to be able to grow an organism to do that. So the recommended test to detect genitalium is a nucleic acid amplification test. And up till a couple of years ago, we did not have any FDA cleared assays. Now, in the last couple of years, there's been 3 genitalium NATs that are currently FDA cleared, and those are the 3 that are listed at the bottom there. What I want to point out about all 3 of these FDA approved assays is they all detect genitalium, but none of them actually detect resistance markers, genotypic markers, which is a huge limitation in our ability to manage patients with genitalium. Now, our lab at UAB, and this is a little bit of promotion here, our lab at UAB does actually have a validated assay for detecting macrolide resistance markers, and we're currently validating an assay to detect quinolone resistance markers, and we published on both of those in the literature. And so I do think until there is an FDA cleared assay, you can send the specimens to our laboratory. Our website's up there, but if you just Google Mycoplasma Laboratory UAB, you will find this lab. And we have a quick turnaround time. We would get the results within 1 week so that you would know next time a patient comes back kind of how to manage that patient. So just because we have a diagnostic test doesn't mean that we should be testing everybody. In fact, the CDC and their current guidelines that just came out in 2021 does not recommend screening asymptomatic individuals. And again, it's just part of us not knowing enough about the natural history to know whether the benefits would outweigh the risk, because there are risks in basically testing for an asymptomatic infection that you may have to treat, not knowing that you really need to treat it. There's the antibiotic side effects, the antibiotic costs. There's the potential stress on the patient knowing that they have an infection that might not be cured in the case of genitalium. But where they do recommend, the CDC does recommend doing testing, is that if you have a patient with persistent or recurrent cases of urethritis or cervicitis, so these are symptomatic patients, have a clinical syndrome, that it's worth testing them for the infection if it doesn't go away with initial therapy to help guide further therapy. And the CDC also recommends that you should consider, not strongly recommends, but this says you should consider testing for genitalium in women with PID. And if you think about PID treatment, we don't really use any antibiotics that are known to be that efficacious against genitalium in our standard PID treatment regimens. So I think that makes sense. I do disagree with the CDC. Hopefully none of them are on the Zoom, or they'll be okay with me disagreeing, that I felt pretty strongly, and I was one of the members that was part of the panel that reviewed the literature for the CDC guidelines. I felt that we should do the genitalium at the time of initial presentation of urethritis or cervicitis, so that if somebody does fail their treatment, you would know whether they have genitalium. And ideally, if you could get a resistance marker, you would know what to treat them with. But for a variety of reasons, that's not what they recommended. They recommended to wait until they come back that second episode of urethritis or cervicitis before doing the testing. I will tell you that there's at least one institution, and this is the University of Washington, where I think they are doing genitalium and they're testing in men with urethritis at the time of first presentation. And I know that there's some others that have been discussing changing to this, but I don't know yet how many are making that change, kind of going against the guidelines.
I have a question about that because I was going to
Sure.
ask you about that. That was going to be my question.
Yeah.
Is what were your thoughts on testing at initial presentation on someone who is symptomatic, obviously not asymptomatic?
Yeah.
What were some of the arguments for waiting for the persistent? You recall?
Cost. Yeah, I mean, cost is one of them, right? So if I guess if a patient is clinically cured, you're doing a test that maybe they won't need, but my concern with that argument is that we know that doxycycline lowers the genitalium load. So sure, we know patients may seem clinically cured, but that the infection can relapse after the doxycycline is gone. But I think one of it is cost. One of it is maybe they felt like they just needed better data to show that doing that test up front impacted clinical management. We all think it's logical, those who actually manage patients, but having that data, I guess they felt like there wasn't sufficient data in that area. And I'm sure they had other reasons that I just didn't know about, but there was a lot of caution about doing that.
Great, thank you. I have been interested in that because that has come up as a question as to why not to test initially, but.
Yeah, I think it's kind of obvious to me that obviously if you wait to test in the second time, then you have to make a decision about whether to treat them for MGent or not when they come back, and then what you would use. And then you really have to wait a whole nother week just to get that result back and the resistance markers back if you can get that test done. And so it just doesn't make sense for the flow of care to not go ahead and do that. And the pathogen's so prevalent now. I mean, in urethritis, some studies showed 25 to 30% of non-gonococcal urethritis is M. genitalium. And so I think it does make sense to me. We'll revisit that a little bit more as we go into the cases, because I think it'll be a little bit obvious in the cases too.
Great. And Kelly Johnson just added that San Francisco is also testing patients with NGO initial presentation for MGent. So she just put that into the chat.
Excellent. I agree with that. So, so let's talk about, the treatment of M. genitalium. So we talked about that, we have a good sense clinically that it causes clinical syndromes, and that it maybe contributes to some complications. We have very good diagnostic tests for this assay, and we have clear-cut now testing guidelines, not screening guidelines, but testing guidelines. So then once you have a positive test, how are you going to treat these patients? And there's really two major considerations, I think, for M. genitalium treatment. One is you have to think about antibiotic resistance, which we're going to talk about in subsequent slides. But also because of antibiotic resistance, you have to think about alternate treatment strategies. I mean, often when we just treat for one antibiotic for a set duration. But with an organism that grows very, very, very slowly, it has a biofilm, which I didn't mention this before, but it does have a biofilm, which also is biofilms are known to help promote antibiotic resistance because it affects penetration of antibiotics. So it grows slowly, it has a biofilm, and we already have resistance. So we have to start thinking about alternate treatment strategies such as combination therapy or sequential therapy, where maybe you treat with one drug and then you follow it with a second drug. And we have to think about alternate treatment strategies when we're faced with this difficult bacteria and its resistance. So the M. genitalium treatments that we have available to us in the United States are fairly limited. There are mainly 3 drug classes that are highlighted or bolded in blue here. Your quinolones, and moxifloxacin is the most potent quinolone we have in the US against M. genitalium. Your macrolides and azithromycin is the one we have the most data for treating M. genitalium. And then your tetracyclines, for which doxycycline is the one that we have the most clinical data for treating M. genitalium. These other antibiotic classes listed are ones that either we don't have published clinical efficacy data or we cannot get access to them in the US. But I list them here as other potential options that perhaps there'll be more data in the future, or we may be able to get access and import it into the US. And I'll revisit that a little bit later in some of our cases. So we got 3 drug classes, okay? The first of those drug classes, the macrolides, has been the mainstay of therapy since MGent was discovered in 1980. That's essentially what we've used. But what's happened over the last, I'd say maybe 15 to 20 years, is there's been an evolution of macrolide resistance. And we've gone from likely a 0% resistance 20 years ago to now anywhere from about 30 to 90% resistance. And the macrolide resistance specifically is in the 23S rRNA gene with certain nucleotide substitutions. But the clinical point about this is that when you have one of these macrolide resistance markers, we call them MRMs for short, the treatment failure rate is very high. One of the best done studies out of Australia showed that 88% of their patients failed azithromycin when they had one of these MRMs. And so, if you're using azithromycin empirically, we definitely run the risk that a patient's going to fail treatment. And we've probably done this to ourselves in that we use azithromycin for almost any type of infection in this country. So we have really, really heavy use of this antibiotic. Can you guys still hear me okay? Just checking in.
Yes.
Yep. Okay. Make sure I didn't drop off or anything.
No, we
Okay.
can hear you.
All right. And so I'll show you really quickly a couple of studies which you might find of interest. So our group here at UAB, we recently did a prospective study that was published where we basically enrolled these women that were seen in 3 different OB clinics, and we were collecting basically remnant specimens and testing them for M. genitalium in these pregnant women. These are women just getting kind of routine prenatal care. And we tested basically a vaginal swab in these women, and we found that 8% had M. genitalium. And when we did the macrolide resistance marker testing, 41% of them had macrolide resistance markers. And there's been another study that came out since we were publishing our study that showed 31%, a study out of UT Southwestern. So it's fairly common. But we went back and now are just writing up a second study where one of my colleagues named Akila Subramanian, she had this access to these specimens from a cohort from studies that were done basically 1997 to 2001 in the same kind of population of pregnant women seen by OB providers here at UAB. They were participating in prenatal or preterm birth studies, and there were a variety of different studies. But she had these stored specimens. We tested about the same number from this earlier cohort. We tested cervical vaginal lavage. The prevalence of M. genitalium in that cohort was 11%, so it was still prevalent back then, but there was not a single isolate that was an MRM. And so, granted, just a relatively small number of isolates if you do the math there, but still, we just did not see any that were MRM. And so that does lead me to believe, that this is one piece of evidence that does suggest that with the own population, macrolide resistance to MGen has emerged over the last 20 years.
Just as a question, what did you do with that, since it's a prospective study? What did you do with those results? Did you have the results real time? Did those patients get treated? And since doxy is not recommended in pregnancy, do you know how that was handled?
Yeah, I did. So I was the PI of the study. So it was written as a research-based only study. I mean, we basically collected remnant specimens. The women were de-identified. We had no contact information. We simply just tested these remnant specimens. So, and we knew that going into it. There's no recommendations to screen these women for MGen. So our study was basically kind of abiding by what is routine clinical practice right now. But it was really to get an understanding for how prevalent the bacteria was and macrolide resistance, so that in that instance, maybe you did want to treat a pregnant woman, maybe she has cervicitis or concerns of a PID or something else, you would have a sense for whether macrolides might be an option.
Did you look at the outcome of that? Like those?
We did. Yeah, we actually did. And it's published. So I can tell you quickly what the outcomes were, but you can let me go back to that slide.
I can look at the reference.
Yeah, it's here. It's actually published online. It's not even published in print yet. We actually did a chart review on the ones that delivered at UAB. So there were some that came for care because they were maybe higher risk but didn't deliver at UAB. So it wasn't all 224 women, but it was the majority of them delivered. And we looked at preterm birth. We looked at the birth weight. I think those are the two main ones. There might have been one other one that was just another marker, kind of a preterm birth. And in all of those, we saw that the ones that had M. genitalium had a higher frequency of those, complications. But because of the sample size, it was not significantly different between the, those that did not have M. genitalium. And it wasn't really designed to look at that. I mean, it's one of those, secondary outcomes. If you want to design that kind of a study, you probably need 1,000 or more women. I mean, it needs to be a much larger study. Other questions on this point? We've been involved in many of the studies published in the US looking at just the frequency of these macrolide resistance markers. And this slide shows it quite well here that the prevalence of these MRM, macrolide resistance markers ranges from about 31%, which that was the pregnant women in Houston that I mentioned, all the way up to 94%, which is an MSM cohort that was in Seattle. MSM definitely have a higher frequency of MRMs. That wasn't surprising to us since we have seen that with other STIs and resistance and MSM population. But I think just if you look at these numbers across the board from these different sites geographically, most of them you're around 50 or more % having MRMs in their population. So that really translates to trying to empirically treat M. genitalium with a macrolide, probably 50% or more of the time that patient's going to fail that macrolide. You might not know it clinically, but if you microbiologically, if you assess them for that, they're likely going to fail it. The cure rates overall were really nicely laid out in this meta-analysis here that shows you prior to study conducted in 2009, the cure rate was about 85%. In studies conducted after 2009, the cure rate's about 67%. And some of the more recent randomized controlled trials in men with urethritis, the cure rates dropped below 50% for macrolides. And so they just are not great drugs anymore for M. genitalium. And now it doesn't matter if you have a resistant strain, it doesn't matter whether you use a 1 gram dose or use a more extended regimen where you give a gram followed by maybe 500 milligrams for another 2 to 4 days. That longer regimen still won't work when you have these macrolide resistance markers for most of your patients. So after macrolides, really quinolones are now our best drug in the US to treat M. genitalium. And it's actually pretty common to find quinolone resistance mutations in M. genitalium if you just look for them. But a lot of those resistance mutations with quinolones do not correlate with treatment failure. There's really only been one mutation that's called the S83I that's in the PAR-C gene. That is the one that has been fairly consistently associated with treatment failure in the literature. Because of that, it's also the most prevalent quinolone resistance mutation, I think because people are failing treatment with moxifloxacin, and that's why you're seeing more of it. There's not been a lot of studies in the US looking at the prevalence of this marker, but in the 3 studies that have been published now, we were involved in a couple of those studies. The prevalence of this PAR-C S83I ranges from about 6% to 30%, highest in men who have sex with men. And typically when we found that PAR-C quinolone resistance mutation, we also found the macrolide resistance mutation as well. So these would be multi-drug resistant strains that are likely to fail treatment with both macrolides and quinolones. And moxifloxacin used to cure essentially 100% of M. genitalium. Up until maybe the last 5 to 8 years, we've started to see the rates drop now into the 60s to 80s percentile range. And that drop has been, because of resistance development.
Just to clarify quickly, these are as a post-doxy, or these are monotherapy with?
These are monotherapy studies,
right.
Yeah, monotherapy. And so I guess hopefully the point I've made is that we're seeing the evolution of macrolide and quinolone resistance with M. genitalium, and it has important implications on, I think, treatment outcomes. But we do not actually have at least a federally funded surveillance program for M. genitalium, prevalence and resistance like we do, for instance, for gonorrhea. But many of us in the field has felt that this is really important. And so back in 2020, Lisa Manhart from the University of Washington and others kind of took the lead in trying to get support to do this type of a study. And we were able to get support from Hologic actually to do a pilot surveillance study for M. genitalium. And this is ongoing. You'll see the first paper come out probably early next year from the initial data. But it's a collaboration between the University of Washington and 7 other surveillance sites. And you can see those sites listed here. Birmingham is one of them. And we may have other investigators actually on our call here today or Zoom today. But it's an ongoing study where each year we collect urogenital samples from 3,200 men and 3,200 women, which is 800 per site. And we basically look at the prevalence of M. genitalium and macrolide and quinolone resistance markers. The testing for that's actually being done at the University of Washington, but the patients are being enrolled at University of Washington and those 7 other surveillance sites. And there is, just from the preliminary data that I've seen myself, there is actually quite some diversity in the macrolide resistance at different sites in the country. but it's high enough in all the sites that it's clinically relevant. And so I'm just letting you know about this, and just to stay tuned that, you may see some of this data published by early next year. And we don't know how long this study is going to continue. I think it's supposed to go through 2023, but beyond that, there's not a contract or anything for beyond that. So we'll have to see. Ideally, this is something perhaps that might get picked up by CDC or others in the future. So, but after macrolides and after quinolones, what are you going to do with patients who are failing treatment? Well, that really just leaves tetracyclines as the only drug class that we have in the US that there is some clinical efficacy data published. And unfortunately, the efficacy is not good for the main tetracycline, doxycycline, which is what we have used for genitalium. So the cure rates for most studies are less than 50%. And in the earliest, some of the earlier studies, there was no clear association between treatment failures and doxycycline resistant strains. However, if you recall that caveat, there's only a few places in the world that have actually been growing these strains. So it's not like we really looked that closely to see. People have looked for one specific type of genotypic marker for tetracycline resistance called the TET-M, but there are several different mechanisms of doxycycline resistance. And so, I don't think we've appropriately looked to know how common doxycycline resistance is in M. genitalium and whether it truly is associated with treatment failure or not. What we can say about doxycycline is, even though it doesn't cure most M. genitalium infected patients, it does lower their bacterial load. So that would give it a potential role in a sequential treatment strategy where you lower the load with doxycycline, and then you come in with a second antibiotic, and by lowering the load first, you would lessen the likelihood that that resistance will develop to that second antibiotic once you give it to the patient. Quinolones are well known for developing resistance on therapy, and so that's less likely to happen if you can lower the bacterial load. So all that being said, we've recently identified 2 cases actually of M. genitalium that were resistant to tetracycline. It's the first cases that I know of that have been discovered, and they had higher MICs to doxycycline as well. And I'm going to talk about those in one of my cases in just a little bit, but I want to highlight that just to reiterate the point that there's probably more cases out there, but we just aren't really looking for them because we haven't known, either we haven't been able to culture them or we haven't known what the right resistance markers are to be looking for to genotype for resistance. Any questions? So then, what are you going to do now, knowing that we're really getting to a point where, at least in the US, we have very limited treatment options, and even worldwide, there's not a lot of other treatment options after ours. And so this concept came about called resistance-guided sequential treatment, which is where you take a patient who has one of these clinical syndromes that might be due to M. genitalium, and you go ahead and do the M. genitalium test right up front. You don't wait till they come back after failing the initial drug. You do the testing right up front. You give them doxycycline for 7 days for that clinical syndrome. And if the test comes back for M. genitalium, you want to bring them back and treat them with a second drug. Even if they're, quote, clinically cured or feeling better, you want to go ahead and treat them with a second drug. And ideally, if you can get macrolide resistance marker testing wherever you are, if you can get that testing, your second drug, if it's negative for the MRMs, is going to be an extended azithromycin regimen. Not 1 gram single dose therapy, but 1 gram followed by 500 milligrams a day for 3 days. If they do have a macrolide resistance marker MRM, then you would, not give them a macrolide. You would give them a quinolone, which in this country you give them oxyfloxacin, but outside this country, some use a different quinolone called citalfloxacin. You would give them one of those for 7 days. So that's the concept of resistance-guided sequential treatment. And 2 of the best studies that have been published looking at this were both out of Australia. Both of them had a prevalence of these macrolide resistance markers about 70% in their populations. And they included both men and women, including MSM, in both of these studies. And the outcomes were pretty similar between the 2 studies, that if you did not have an MRM and you got the sequential therapy, which was doxy followed by azithro, your cure rates were 95%. If you basically did have an MRM, which means you got a quinolone, one of them I think was moxy, the other was citalfloxacin, the cure rates were 92%. And these cure rates in the 90s percentile range is better than what we've seen with monotherapy with, for instance, a quinolone or a macrolide. And so I do think it kind of made sense, if you're not worried about doxycycline resistance or tetracycline resistance, that you might do this kind of resistant guide sequential treatment. And essentially, everybody got on board with this concept, and you see this recommended now, and major guidelines across the world that we should be doing this resistant guided treatment strategy. This is for uncomplicated M. genitalium infections. However, as I mentioned, the concern about is this doxycycline resistance. And we can maybe have a debate about this or discussion about this afterwards, that I really worry a little bit about that if we continue to use doxy in this role, knowing that it won't cure these infections, simply it's just going to lower the load, that we might be selecting for more doxy resistance in the future. The CDC in their guidelines for treatment, again, they do recommend sequential treatment strategy, but they acknowledge that, because we don't have FDA cleared assay in the US for getting these macrolide resistance markers, that you might not know if they have an MRM. And so what the CDC is, in one of their boxes, they say that if you don't have that MRM testing available, then you start with doxy for 7 days and go straight to moxifloxacin for 7 days. They don't recommend giving somebody a macrolide just to see if it will work, and then if it fails, to bring them back, because I think the likelihood it would fail is over 50% of the time. So that doesn't make sense for I think most patients. I'm going to stop right here. I think this is a good stopping point before we discuss the 3 cases that I have, to see if there's any questions about what we've talked about so far.
Thank you. Quick question, and I guess you may cover this in your cases, but so what's the expected natural history, say if we are in a situation where we cannot treat for a variety of reasons? So for example, I have a case where this lady has what seems to be vaginitis and discharge. She has anaphylaxis to moxifloxacin, hives to doxycycline, azithromycin monotherapy someone tried and hasn't worked. And so we are weighing the options, and the resistance test is pending. But so I guess we are weighing the options of not treating at all and just watching her versus, taking a risk with doxy-moxy, with anaphylaxis to moxy. So I guess what's the natural history if I'm counseling this person?
Well, one of my cases is going to talk about kind of salvage regimen. So that part I'll wait to the cases. The natural history, people do clear this infection over time. Their own immune response will get rid of it. But we don't really understand that well. There's been at least 3 published studies in women where they've kind of tested stored specimens for women that didn't receive therapy to cover M. genitalium, and they've looked at how long it took to clear them. And in those 3 studies, these were asymptomatic women. In these 3 studies, the women, half or more cleared it within just a few months. So we do know that at least asymptomatic women can clear their infection within a matter of months. We don't know whether they had any silent complications like PID, but we know that they can at least clear it without therapy. But for people who are symptomatic, who failed therapy, we don't know. One of the cases I'll tell you about has had it for over 4 years. And I've seen a couple of guys in clinic that have had it 1 over 5 years and 1 over 10 years. But they may not be the norm. They may be the exception. They may have some other immune problems that are allowing the infection to persist a lot longer in them. So we really don't know the natural history in people who are symptomatic, who have failed treatment. And we really don't know much about the natural history of asymptomatic infection in men, but at least in women, asymptomatic infection, that many will clear it spontaneously within a matter of just a few months.
Thank you. Yeah, sounds like that too. Then needs more work, but
yeah, definitely. Other questions before we go through these cases?
Will you address treatment for pregnant women in your case?
Yes, I will. Yep, that's case number 2, actually.
There's a question in the chat from Ina, basically wondering whether you know about a timeline for macrolide resistance testing. Any info on that?
Either a lab developed test, by
Or
one of the commercial labs, or FDA approved test will.
Yeah. All right. Well, so UAB already has a validated test, and you can order that for your clinical care. So if you ship it to our lab at UAB, you'd have the results within 7 days. So right now, we're the only one that I'm aware of that's actually doing it for clinical care purposes. There are some other labs that do it for research purposes. There are a couple of companies that are looking at their NAT assays having macrolide resistance markers. One of them is one of the companies that already has an FDA cleared test. And, I think they're interested in it, but I don't know about a timeline and submitting to FDA, et cetera. One of the other ones does not have an FDA cleared test in the US, but theirs is used in other parts of the world. And I think they're looking at whether they can get that approved in the US. But my gut feeling is it won't be soon. It might not be within even the next 1 year. And so I think that at least in the US, our lab's the only one that I'm aware of right now that can actually do this. And we have the capacity to do it, I think, on a pretty large scale. We haven't really promoted it. I mean, obviously I'm talking about today's presentation, but we certainly have that capacity to do that. Other
Great.
questions?
There was a question in the chat also about any data on susceptibility to zoliflodacin or geptidacin.
Actually, I'm not going to talk about those just because those are ones that we wouldn't routinely use in care for kind of other reasons. So we haven't really, our lab hasn't really tested that closely, at least recently. So I really don't have data for that. My sense is that those would likely not be good antibiotic choices anyway, just because of the quinolin resistance development having such a low threshold. I'm going to talk about in these cases a couple other options which I think may be better than those antibiotics for salvage therapy.
Great, thank you. I think maybe we'll go to the cases just in the interest of time. So thank you so much.
All right, so so the first case, so I've been involved in all three of these cases, either seen the patients myself directly or as a consultant. The first case is a 32-year-old non-pregnant female. She's had prior bacterial vaginosis and she's had a known serious allergy to levofloxacin. It was not anaphylaxis, but she had severe tendonitis and dizziness and arrhythmia and some other problems. So it was pretty bad. She comes to her GYN provider because of vaginal symptoms. She was diagnosed with BV and given clindamycin because of an intolerance to metronidazole. They actually didn't do STI testing. I'm not sure why they didn't do that in this first episode. This was not at UAB. This was a kind of a community provider. But her vaginal symptoms did not get better with the clindamycin, and she came back. And then that provider tested her for kind of the routine STIs as well as genitalium. And she was positive for genitalium, but negative for the other routine bacterial STIs, chlamydia, gonorrhea, as well as trich. And so what the provider did was the provider prescribed this patient 7 days of doxycycline, and then kind of went ahead and referred this person to a local ID specialist, infectious diseases specialist in the community, who decided to give this patient azithromycin, the Z-Pack dosing, which is not the recommended CDC recommended dosing for genitalium. Z-Pack is 500 milligrams day 1, 250 milligrams days 2 through 5. The CDC recommendations are 1 gram on day 1, 500 milligrams for the next 3 days. But essentially, this patient did get sequential therapy in that she got doxy, then she got the Z-Pack after that. And basically, her symptoms got a little bit better with the doxy, azithro, but they never resolved. And during this time, she was not sexually active with her current partner, a male partner, and that partner had tested negative for genitalium. So it wasn't like a re-exposure issue during this time. And so basically this patient got referred to me, and the question was, what do you do now with this patient who has persistent vaginal symptoms and needs to be evaluated and managed? Before I get to what we did, I want to make the point that this patient actually did not get speculum examinations done, at least the second time, to kind of show that she had persistent recurrent cervicitis. If you recall the CDC's guidelines, that you would only do MGen testing in women that have recurrent persistent cervicitis. But that's not really practical for kind of real world care, because in real world care, we often don't do speculum evaluations anymore. So we don't know whether women have cervicitis. We have to go on the symptoms that might be from cervicitis, such as vaginal discharge. So I think my point is, if you have a female that has recurrent persistent vaginal discharge and you've excluded the vaginitis causes and the other STIs, you should definitely be thinking about genitalium and test that patient for that. Even though it's not cervicitis, I think it's probably representative of a cervical infection in those patients. But what we did in this case is that I tested her again just to kind of be sure. She did have persisting MGen infection, and we did the MRM testing, and she was positive for MRM, so she had a macrolide resistant strain. The time that I saw her, I went ahead and treated her at that first visit, even though I sent off her test because I was pretty convinced that she had genitalium. And I used one of the salvage regimens called minocycline, which is an older tetracycline We prescribed it 14 days for her. Her vaginal symptoms resolved. And we actually were not going to get a repeat MGent test on her, but she decided on her own to go get one done, which she did 4 weeks later, and it was negative. So she was clinically and microbiologically cured with this regimen of minocycline. And so let me just tell you a bit about minocycline. If you're not familiar with it, it's been around a long time. It's one of the oldest tetracyclines. And we and one other group from Japan have published some case reports on patients that had failed other regimens like doxycycline and quinolone, and we were able to cure them with regimens of the regimen of 14 days of minocycline. And, you know, but there's no randomized controlled trials. There's no larger studies. These are simply case reports that have been used. It does make sense because in vitro, the MICs for minocycline are just a little bit lower than they are for doxycycline for M. genitalium. And it is like doxycycline is generic. It's very affordable, less than 25 days for 14 days of treatment, or less than $25 for 14 days of treatment. But the reason why I would caution you to using minocycline now as your routine kind of tetracycline drug to treat potential MGen is that some patients don't tolerate minocycline well. You know, there's some side effects we don't see with doxycycline that we see with minocycline, and that includes things such as dizziness, vertigo, sensations of numbness, burning, or pain in muscles or joints. It's usually not bad enough for younger patients to stop the therapy, but it's bothersome to them. And so, you know, I do think minocycline is a potential salvage regimen. There obviously is some published evidence that it can cure some people. But we've also had people fail this regimen as well. So there's no guarantee it's going to work, but it's at least one that you can get in the US. It's very cheap. And if the patient's not pregnant, then it makes sense that you could try minocycline. And that's become our kind of go-to regimen for patients who have failed doxycycline and moxifloxacin, or maybe couldn't take azithro or moxi because of an allergy issue. And so back to that question about that patient that had the anaphylactic reaction to the quinolone, had hives to, I think you said doxycycline, and the macrolides didn't work. One option for that patient might be to work with an allergist to see about giving them some prophylactic allergy type of treatment like a Benadryl or something like that, and then put them on minocycline for 2 weeks to see if you can get rid of the infection. So that would be one option. That would be a safer option, I would think, than the quinolones with a known anaphylaxis. So that would be one potential option. But I'm going to talk about a couple other potential options in the last case that I'm going to present. So I'm going to stop kind of here with this case. And I do think you're going to see more of these women with persisting vaginal discharge where you don't have a known cause and they're going to be due to M. genitalium. I've seen one study that's not published yet that basically was looking at women that would have kind of been dubbed persisting vaginitis, and a little bit, you know, close to 10% of these women had M. genitalium detected. And so I do think it's probably contributing to, quote, persisting recurrent vaginitis in some of these women.
Thanks so much. I'm just going to add a couple comments from the chat. One was from Zun Wang, who basically said, related to minocycline, that they've seen folks admitted with idiopathic intracranial hypertension, vasculitis, as a result of dermatologic use of minocycline. So that's an interesting, you know, possible side effect. And then there's a question to you, Will, about, is there any data that demonstrates that doxy-moxi sequence changes outcomes compared to moxi alone?
Of course.
Yeah. So there is the data that was, let's go back. You said the comparing doxy-moxi to moxi alone?
Yeah, that was the question.
Yeah. So that's what these sequential guided, that's kind of what basically, you know, these studies are doing, is that, you know, they're looking at, if you compare sequential treatment to standard treatment, that you're going to have these differences in outcomes. I'll have to pull these papers again. It's been a little while since I've read them. I can't remember the outcomes for the other groups, so I'll have to check on that. But yeah, that's what I recall. I'm pretty sure that that's what they did in these studies, but I'll have to go back and read them again just to verify that.
All right, thank
Another
you.
thing to add to your side effects is erosive esophagitis, and the counseling about a lot of hydration. We've seen that as well.
We see that with doxycycline as well. It's underappreciated, I think, but The other side effect is longer-term minocycline use has been associated with pulmonary fibrosis and other pulmonary complications. But again, that's all longer term. I think those outcomes are all pretty rare. I think in general, most patients will only have some of these more bothersome side effects with insulin. Let's move on maybe to the second case here. This is about a pregnant patient. So this gets to that pregnancy question. 21-year-old pregnant patient, 31 weeks pregnant, presented for initial OB visit, had a malodorous vaginal discharge for 3 days. Pelvic exam revealed white vaginal discharge. The wet mount was unremarkable. Had a multiplex PCR sent for a bunch of different pathogens. And the only one that basically came back positive was M. genitalium. They did not do testing for MRMs because they didn't have it available. And so, the basic question, I think, with this case is, should she have had the testing done in the first place? Certainly the CDC guidelines, the current ones, do not recommend testing kind of first presentation vaginal discharge for M. genitalium. So this is kind of outside the guidelines, but, people do this all the time. People just test them for whatever they're going to test them for. And it was done. So the question is, how would you manage it? I mean, she's symptomatic. It is a sexually transmitted infection. So it would make sense to try to treat her to improve her symptoms and maybe limit transmission, certainly the symptom part. But then what are you going to use to treat this patient? And so if you think about those 3 drug classes, macrolides, tetracyclines, and quinolones, the macrolides are really the only one of those 3 that are considered safe for pregnant women. And so that's the dilemma. So I was kind of consulted on this case. It was not my case. And we had this discussion about what to do. This discussion really comes down to whether you don't treat them, whether you give them azithromycin, or whether you would give them one of these other drug regimens and risk the safety. And we didn't want to do that. So basically, the decision was made after discussing with the patient about the options to go ahead and try azithromycin. It's possible that maybe she has an azithromycin sensitive strain. We don't know that, and it would work. So she was given the extended azithromycin regimen. Her symptoms got better, but they didn't really fully resolve. And so she got another test done about 28 days later, and it was still positive. She's about 36 weeks pregnant at this point. So after further discussion about what to do, which was to try to repeat treatment, knowing that it likely wouldn't work, again, trying one of these other drugs that might not be safe, or just not treating her, not knowing for sure whether that would cause any problems with their delivery. And what was decided by the patient was to hold further treatment until after delivery. She ended up delivering about 4 days actually after that discussion. And I'm not sure if it's the discussion that kind of scared her into delivering or how that all happened naturally, but it did. And the patient was fine. The baby didn't have any known issues during the hospitalization. And she was treated in the postpartum unit with moxifloxacin, or started on it, I should say, for a 7-day regimen. And then this patient, for some social reasons, was kind of lost to follow-up. So there's no follow-up data to know whether she was cured or not. But this really brings to the point, what do you do in women who are pregnant and either you don't know about macrolides or you tried macrolides and they haven't worked? And there really is, honestly, no good solution there. I think if you've not tried a macrolide and you don't have macrolide resistance testing, macrolides are in general safe in pregnancy. So you could try a macrolide regimen like we did here. But if they fail a macrolide, then I'm not sure whether the right answer is to try another treatment where it can put the mother at risk from side effects of the drugs, the quinolones and tetracyclines, or just to not treat them and follow them, where not knowing if it will affect the pregnancy. There's not a great answer there. What I will say is that there is actually one antibiotic that it would be safe to use in pregnancy. We just don't have it in this country. And it's an antibiotic called pristinamycin. Pristinamycin is a streptogramin class antibiotic that's made in France. It's made by Sanofi. It's a pregnancy category B. They have pregnancy safety data, so it's safe to use in pregnant women. It does have in vitro activity against macrolide-resistant M. genitalium, and there are several published studies looking at its cure rates, and it does cure currently the majority of M. genitalium infections. So the problem is, how can you get this drug for your pregnant patient in the U.S.? The easiest thing, honestly, is if the patient has money, they could fly to France and get it. That might be the easiest thing, honestly. It may not be the cheapest way, but it's probably the easiest way. But if you were to try to import it from France to use it for your patient, what you have to do, because I've done this before, not for a pregnant patient, but for case number 3, who's next, is that you have to get FDA approval through this patient expanded access IND program. You have to get approval from the company to get the antibiotic Sanofi. You have to get local IRB approval to be able to give this drug to your patient. And then you have to get patient consent documented to do it. And when we did this before, it took us about 3 weeks. It was a lot of work, but we were able to get pristinamycin imported into the US to treat a patient, which is our next case. So I do think that this is one option. It would be really nice if we can figure out a way, like work out a deal with the FDA to maybe get this antibiotic available for pregnant women to treat them without having the company to, do a couple of large clinical trials that takes millions of dollars and at least a few years to get FDA clearance to do it in the US. Because I don't think there's probably a big investment for the company to do that. And otherwise we probably will not have access to this antibiotic. But this is one option that would be available in theory in the future. Any questions about this case? I mean, I wish I had a silver bullet, great answer, but as if we're kind of stuck
Well, is this
about what to do.
Well, I know this is an older case that happened before you had macrolide resistance testing. I'm just wondering now, if this person showed up today, you would probably test them for macrolide resistance before treating them with Azithro, or would you just kind of say, well, that's the only option we have, so I'm just going to give it to you and see if it works?
Yeah. If I had no macrolide resistance, I'm going to flip it that way. If I knew I had macrolide resistance, the drug, there still is not a perfect answer. I mean, the likelihood is that she's going to fail treatment, at least 10%, or at least probably 80+% are going to fail treatment. But she might be that small percent that doesn't fail treatment and it's safe in pregnancy. So you could make the argument, why not try it? Because we have no other options. Versus if you don't even look for it, it's still your only treatment option. So in pregnant women, I'm not sure how much the MRM maybe impacts because it doesn't change what we're going to do. Perhaps not. Not unless you felt strongly that if it was resistant, why even give it to this patient? Or maybe the patient has known problems taking azithromycin before. Would you risk them having problems again, knowing it was macrolide resistant?
Yeah, well, I think this was actually an STD. This is Kelly. I think this was an STD CCN consult, if I'm remembering.
Yeah,
properly.
it was. Yeah.
So it wasn't that long ago. So I think theoretically,
yeah.
we could have done the macrolide resistance testing, but I feel like the thinking at the time was that we didn't have anything else to give her anyway. So what would we learn from that other than futility, I guess?
Yeah. That's correct. Any other questions about this case, I guess, before we go into our last one?
I think the thing that's tricky also here is that a lot of people are now just getting, and anyone who mentions anything about their vagina is getting one of these multiplex tests. Do you know what I mean? And then with the result, you don't know what to do with it. And especially if they're pregnant, you really don't know what to do with it. And also because there's increased physiologic discharge in pregnancy anyway. So then you're like, God, is this something or nothing? And should I just wait a couple months and it'll resolve on its own? So it's just really challenging. I mean, you could look at it with a speculum and say, well, everything looks great and this looks like physiologic discharge, but it's really, really hard to say.
And it's not like with cervicitis, there's discharge there 24 hours a day.
No, exactly.
It's somewhat of a sampling approach. Whenever you take a look, it may or may not be there. I mean, I agree with you. There's a challenge, but there is, to me, really no great answer on it. I wish we could get those multiplex tests. I mean, I have issues with those multiplex tests. I guess I'll just leave it at that. They're inappropriately used all the time. But
all the time.
Yeah. Okay, well, let's go into our third case. Many of you have heard about this case before. I think I presented this patient probably the last time we did one of these a few years ago. We still are following the same patient.
It was earlier on in his treatment.
Yep, still following this patient. So I'll just quickly catch you up to date at what's going on with this patient. So this was a young adult male, had congenital agamoglobulinemia, which means he has no functional antibody. So he has to get antibody infusion once a month for the rest of his life, or he will have a life-threatening infection, but he obviously lived into young adulthood. He became sexually active and he got urethritis, and it was due to genitalium and not other STIs. And, we did the initial treatments with doxycycline, with azithromycin, with moxifloxacin, and minocycline. He had failed all these treatments and was symptomatic. He was continued to fail them. And so, that brought us to this point about what other salvage off-label MGent treatments are available in the US once you get past those 4 drugs that are listed there. There are really only two that I'm aware of that might be promising, but neither have published clinical efficacy data. And one is a very new tetracycline called omadacycline. And this is a newer tetracycline that is FDA approved for treating skin infections and community-acquired bacterial pneumonia. It is orally, 2 tablets once a day. It's not generic because it's new and it's very expensive. It would be like $3,000 or so out of pocket for a 7-day course. And because it's not FDA approved for genitalium, most insurance companies are not going to cover that for that use. It's well tolerated, side effects similar to doxy. And, you know, we've looked at it against several clinical isolates that we've grown in culture. And we just actually published this paper. It just came out like about a month ago. I'm showing you part of the table that's in the publication. This first isolate is the ATCC control strain. So it's a very sensitive strain of M. genitalium. And then one of our patients is case 1, and there's another patient that's actually case 2. So we have 2 patients that have tetracycline resistance, and you can see their MICs to tetracycline are 8 to 16, and their MICs to doxycycline, this one too, is at least 4-fold higher than what we typically see. And so you would almost certainly fail treatment with that type of an MIC with doxy. What was interesting is that the omadacycline MICs were lower than all the other, this is minocycline here, they were lower than the other tetracyclines. And in this one resistant patient, case 3, we've had a few isolates grow. And you can see as he evolved into tetracycline resistance, the omadacycline MICs never changed. So it seems like that basically omadacycline may maintain its activity against TET-resistant strains. But we simply have not had enough clinical use, and there's certainly no published efficacy data to know whether it's going to work. It's going to get good levels, in the site. I feel confident of that. So you would think it would work better than the other tetracyclines, but I have no, published evidence to prove that point. But I do think this is one potential option that maybe if there's a way to get this lower cost, that it might be one worth trying. And by the way, we've actually figured out, we're writing up the paper right now, but I'll just go ahead and tell you that the mechanism of resistance is actually efflux. It's not changing of the binding site, ribosomal alteration. And so we found certain mutations in the sequence of efflux transporters. And we're hoping with some more studies that we can validate these might be the important genotypic markers to look for tetracycline resistance. And if we can validate that, then we would have a way, without growing these strains, to actually look for tetracycline resistance in the future. The one other treatment besides the omadacycline is a drug called lefamulin or lefamulin, depending upon how you say it. And this is from a newer drug class called pleuromutilins. And it actually is FDA approved for treating community-acquired bacterial pneumonia. So there is some good safety data in non-pregnant individuals. It's dosed twice daily. It's also very expensive, about $2,000 or so out of pocket for a 7-day course. Its side effects are similar to azithro, so typically tolerated well. It is definitely not to be used in pregnancy. They've shown fetal harm risk in animal studies, so it's not one you want to use. But it has very good in vitro activity against, even better than omadacycline against M. genitalium, but there's just simply no published data on it. And that's its big limitation. I've actually used it in a couple of people and it didn't work, but these were guys that had infection for years. And I suspect that there may be something else with their immune system, like our patient 3. There is actually a way to get lefamulin at no cost. And so I wanted just to briefly mention this. And to get more information, you can contact Lisa Manhart at the University of Washington, because she's the PI of this ongoing study. Basically, she's getting the company that makes lefamulin to sponsor this study, where basically if you have a patient that's failed the usual M. genitalium treatments or may have an allergy to them and can't take them. So for instance, if you have contraindication to moxifloxacin, like one of the questions earlier, the patient was anaphylactic to quinolones, you can basically refer this patient to this study. There's a red cap form that you would complete and everything with some information. And the patient is going to get randomized to either lefamulin alone or doxycycline followed by lefamulin. But they would get those treatments free, is my understanding, as well as any of the associated testing. If there's anybody on the line that wants to comment any more about this, but this is something that's just started up, but it's definitely something that you should think about in your patients. And so you can contact Lisa Manhart about this study, because I think she would be happy to send you more information, or of course me, I have some more information. I can send you this. There's a printout, a sheet that I can email you, and you can disseminate this if you want as
It would
well.
be fabulous. Yeah, thank you so much.
Okay, I'll email it to you after the talk.
Okay, I think we're a little bit after 11
Okay.
o'clock, so some folks are streaming out, but I mean, I
That's
guess we just
fine.
want to stay
I'll just
on.
basically say what happened with this case is that this patient's failed omadacycline, nifamylin, and pristinamycin. He's taken all of them, and he still has urethritis now over 4 years. He's still symptomatic, and so he's basically incurable right now. I think we're going to start to see he's immunocompromised, which is part of the problem here. But I do think we're going to start to see some people like this eventually that we can't cure, and we definitely need new drugs, better drugs for treating M. genitalium. That's really my final point. And I'll be happy to stick around for a few more minutes for any other questions or comments that others have. And I'll go back and look again at those sequential treatment studies just to verify about the single drug. Somebody asked me about the single drug treatment, because I want to make sure I'm not getting that confused with another study. So I'll go back and I can email you that just for clarification on that point.
Thank you so much. This has been fabulous, and I
Yeah.
really appreciate you taking the time to speak with us. And you're getting a lot of thank yous in the chat that I know that you're not seeing, but yeah, awesome.
Okay.
Thank you so much.
Sure.
I actually have one quick question. I'll try and squeeze in. What are your thoughts on treatment of asymptomatic female partners? And do you who test positive? That was
Yeah,
a question from Kathy Shu that she wanted to bring up.
Yeah, that's a great question, because basically there's almost no guidance about what to do in partners. If you look through the guidelines, it's kind of like missing. So in general, even though the typical traditional partner treatment strategy has been just to treat people as a contact to an STI, the concordance rates with M. genitalium partnerships is really not that high. And considering the side effects of the drugs and the challenges of curing it, we typically would test them first to prove that the partner has M. genitalium, and then we would treat them. And when we treat them, we try to use the same treatments that we use for the patient, if at all possible. We don't do a test to cure if they're asymptomatic. And that's really been our approach. But there's really not good partner studies to guide any of this. It's all anecdotal kind of experience that I'm aware of right now.
So asymptomatic positive partners you treat and you offer them oxy.
Yeah, I treat them. Yeah, exactly. I try to treat them with the same treatment regimen as the patient, with the rationale that if you can cure the patient, you hopefully cure in the partner. Plus, in partnership, sometimes when one partner gets a different drug than the other partner, it causes like different,